Hello. Hello.
Hello, ma'am. Good evening. Am I audible to you?
Yes, yes.
Just give me a minute, ma'am. We already are live,
Okay.
so we will be starting very shortly.
No problem.
Ma'am, with your permission, shall I start the session? I will give the introduction and post that, and I will hand over the session to you.
Sure.
A very good evening to all of you present on today's session on pulmonary tuberculosis. And to present this topic, we have with us today as a keynote speaker, Professor Dr. Jayalakshmi TK. Ma'am has done MBBS, MD, DETRD, FCCP, MRCP from UK Medicine. Ma'am is consultant at Apollo Hospital, Mumbai. And today, ma'am is going to share his precious knowledge on pulmonary tuberculosis. Let me share an overview of today's session. Tuberculosis is the 13th leading cause of death and the second leading infectious killer after COVID-19 as per the World Health Organization. The prompt diagnosis of tuberculosis is essential for the community public health infection control measures as well as for the ensuring the appropriate therapy for infected patients. Now, without wasting any more time, I would like to hand over the session to Dr. Jayalakshmi ma'am. Ma'am, over to you. Please start.
Thank you so much, Nishita. I'll just share the screen. Is my screen visible?
Yes, ma'am, your screen is visible. Can you please make it in a full screen?
Yeah.
Yeah, it is fine. Please start.
Okay. So thank you. So recently we had celebrated or commemorated the World Tuberculosis Day. So that was on 24th March. And the theme for our World Tuberculosis Day is, yes, we can end TB. So we will just go through our presentation as to the history of tuberculosis, what is the treatment available for tuberculosis, how it has changed over the years, and what is the current treatment for MDR tuberculosis. So tuberculosis is an ancient disease. Even spinal tuberculosis has been identified in Egyptian mummies, and the history dates to 1550 to 1080 BC, and it has been now identified by PCR that even in these mummies there was actual tuberculosis germs present. So this is not a new disease, it is a very ancient disease. It has affected tuberculosis and historically it is called consumption, wasting disease, white plague. It was a death sentence for many in the Western countries as well. Till the Industrial Revolution in the Europe and United Kingdom, there were very high fatality rates for tuberculosis. Until 1800, people believed TB was hereditary, and there were families who would be plagued with tuberculosis. In 1865, it was proved that TB was infectious, and in 1882, Robert Koch discovered the Mycobacterium tuberculosis organism. So after that, initially there was sanatorium treatment. It was known that it is an infective disease, so the patients were isolated. They were given good air, clean air, good food, good rest, and about 40 to 50% of the patients would improve temporarily, but the 90% would die over the 5-year period of developing tuberculosis. So the fatality was very high. In 1943, for the first time, a drug called streptomycin was identified, which could treat tuberculosis. From 1943 to 1952, two more drugs were discovered, that is isoniazid and PAS. And after that, we have had much more drugs, like pyrazinamide was discovered, ethambutol was discovered, and TB cases started slowly declining. But in the 1980s, there was again an unexpected rise in TB cases, and this happened because of the AIDS pandemic. So the isoniazid, ethambutol, pyrazinamide, rifampicin, streptomycin were the main drugs were all discovered up to 1963. And this is still the mainstay of tuberculosis treatment now, almost 60 years after the rifampicin had been discovered. So there was a paucity of new drugs in the field of tuberculosis. As such, because tuberculosis was not really a menace in the developed countries, there was less research to developing new medications till the emergence of multi-drug resistant tuberculosis. Once the multi-drug resistant tuberculosis started emerging in the 20 after the 2001, then and the numbers started increasing. Now, if you see in Russia, most of the patients have multi-drug resistant tuberculosis. There was a spread of MDR tuberculosis in many countries across the world. Now there is a lot of research on newer medications, and indeed we have newer medications discovered for multi-drug resistant tuberculosis. But we will go to the basic treatment of tuberculosis. Even in India, we had tuberculosis since 1500 BC. And disease is attributed to fatigue, worries, hunger, pregnancy. Number of Sanskrit manuscripts are there which has been which have described tuberculosis. We have many sanatoriums in India. In the early 20th century, these were set up. We have the Stop TB program was started in 1993. 1997, we had a revised National Tuberculosis Control Program. 2005, we have the revised National Tuberculosis Program, which is now called as NTEP. So NTEP and recently the NTB program has been announced to reduce significantly the rates of tuberculosis. So this is the PMDT, that is the treatment of multi-drug resistant tuberculosis. So the number of centers have increased vastly. And the number of TB cases diagnosed, that is the drug-resistant cases diagnosed itself, is 3.5 lakhs. And most of whom have been put on treatment. And there are also number of XDR TB patient and isoniazid resistant TB patients who have been diagnosed and put on treatment. So basically from 2007 up to 2012, there is the initiation of DRTB services, then there is the expansion of DRTB services and the National Strategic Plan for Ending Tuberculosis. Important thing what I want to talk to you about in treatment of tuberculosis is the latent tuberculosis treatment. This is very important in the, if we want to end tuberculosis or if we want to prevent the development of newer cases of tuberculosis, the latent tuberculosis treatment is very important. So this can be given as isoniazid and rifampicin in the form of once weekly regimen, and total only 12 doses the patient has to take. Or patient can take only rifampicin tablet for a daily for a period of 4 months. Or patient can take isoniazid and rifampicin tablet daily for a period of 3 months. Or patient can take only isoniazid for a period of 6 months or 9 months. So this is the basic regimen for the prevention of tuberculosis. So prevention of tuberculosis is recommended for patients who have been confirmed to not have any active tuberculosis, but who have been exposed to a sputum positive case of tuberculosis. So there will be 3 groups, basically: household contacts, HIV positive patients, and other risk groups. So first you see if the patient is symptomatic, rule out any active tuberculosis, investigate for active tuberculosis by doing the X-ray sputum. If all this is negative, then you can give the preventive treatment and follow up for active tuberculosis, even if they have completed preventive treatment. So infants, patients living with HIV, household contacts of the TB patients below 5 years, above 5 years, they are all eligible, or children or adults on immunosuppressive therapy, on silicosis with silicosis, anti-TNF treatment, dialysis patients, transplant patients are all eligible for taking the preventive treatment. It is contraindicated in active TB, acute or chronic hepatitis, if the patient is on other hepatotoxic medications, if the already patient has peripheral neuropathy, we cannot give isoniazid, or if the patient is allergic to any of the drugs. Now we come to the, even the contacts of drug-resistant tuberculosis have been recommended to take the TB preventive treatment, depending, and the drug recommended is levofloxacin for a period of 6 months if the patient is sensitive to levofloxacin, or 4 months of rifampicin if the patient is only resistant to isoniazid. So this is the recommended treatment for the preventive tuberculosis treatment, either with levofloxacin or with rifampicin. Now we coming to the tuberculosis guidelines. So when we come to the treatment of multi-drug resistant tuberculosis, either we can include all the three medications like levofloxacin, moxifloxacin, bedaquiline, linezolid from group A. Then there is group B, clofazimine, cycloserine or terazidone. And group C, that is ethambutol, delaminate, pyrazinamide, imipenem, meropenem, amikacin. So we have classified all the medications available for TB in three groups, depending on the sensitivity or how powerful anti-TB medications they are. So this is specifically for the treatment of multi-drug resistant tuberculosis. This is the longer MDR-TB regimen. Also, we have a shorter MDR-TB regimens where bedaquiline and moxifloxacin are used. So basically, any patient who's going to undergo MDR-TB treatment will undergo the pre-treatment counseling, will be informed about the lab report, will be told about the treatment and adherence to the importance of adherence to the treatment. Treatment may be changed depending on the sensitivity reports. Cultures will be done repeatedly. Family needs to be reassured against stigma. Infection control for the relatives is important. Family planning is important. And if there is rifampicin resistance, so initially if the patient comes to you with the symptoms of tuberculosis, first we will check for the rifampicin resistance. If the patient has a rifampicin resistance, then the patient will be again tested for the other second line drug resistance. And after completing that, the patient will go for the shorter oral bedaquiline regimen containing MDR regimen or the longer oral XDR-TB regimen. And then additional resistance or intolerance, if it is there, then again the patient will go on the longer oral TB regimen. So basically, we need to check sugar, check for the HIV, do the complete blood count, do the liver function test, thyroid test, urine examination, electrolytes, pregnancy test, chest X-ray, and ECG. Shorter bedaquiline containing regimen of 9 to 11 months is recommended in eligible patients with confirmed MDR or rifampicin resistant TB patients. So now we used to have TB treatment, especially for MDR TB, lasting for 18 months to 24 months with 6 months of injections. Nowadays, the injections are not recommended, and patients are recommended to have just 9 to 11 months duration of treatment with the advent of bedaquiline. So as I said, there are new drugs, 3 new drugs, bedaquiline, pretomanid, and delaminate, which are available for the treatment of MDR tuberculosis, and these have even been proposed to reduce the duration of the MDR TB treatment. So we have 4 to 6 months of bedaquiline, levofloxacin, clofazimine, pyrazinamide, ethambutol, high-dose isoniazid, ethionamide, and followed by 5 months of levofloxacin, clofazimine, pyrazinamide, and ethambutol. So from the start to the end of the 4th month, you give the 6 or 7 drugs, and then follow it up with 4 drugs of treatment. So, as you can see that with the advent of the newer regimens, the treatment of MDR TB and the rifampicin resistant TB has undergone a sea change. And these drugs are available in the National Tuberculosis Elimination Program. And these drugs are very safe. Bedaquiline especially has proved to be a very safe and very effective medication. So basically for patients who have rifampicin resistance, who have no fluoroquinolone resistance, and who even in children aged 5 to 18, also it can be given. And only they should not have exposure to these second line medications before. They should not have very extensive TB, no severe extrapulmonary TB, and they should not be pregnant or lactating. So some of these patients are excluded from the bedaquiline regimen, and they will go for the longer oral regimen. Or if they have any arrhythmias, or if they have any QTC prolongation, or if they have any risk factors for any heart disease. So basically, we will not go too much into detail. So the dosage of the oral bedaquiline containing regimens are these. We can have high-dose isoniazid, ethambutol, pyrazinamide, levofloxacin, bedaquiline, clofazimine, ethionamide, pyridoxine. So this is the regimen which most of our patients who are eligible for the bedaquiline containing shorter oral regimen are recommended. Those patients who are not eligible for this will go for the longer oral regimen, which again includes bedaquiline and levofloxacin and linezolid, clofazimine, and cycloserine. So these are the main medications which are used in the treatment of multi-drug resistant tuberculosis. Bedaquiline and clofazimine, we should remember, may lead to cardiotoxicity. Linezolid may cause anemia, thrombocytopenia, peripheral neuritis, optic neuritis. Cycloserine should be used carefully in pre-existing seizure disorders, and clofazimine can also cause dark brown discoloration of the skin. So these are the doses of the drugs for the longer oral regimen. These are the replacement medications if one of the medications cannot be used. And also I would like to talk to you about the B-PAL regimen, which is a new suggested regimen for patients with fluoroquinolone resistance, bedaquiline, prednisone, and linezolid. This regimen lasting for 6 to 9 months can be used for in research conditions for TB, which is resistant to fluoroquinolones, who have no previous exposure to bedaquiline. And so this is a new recommendation for a extended pre-XDR tuberculosis, that is fluoroquinolone resistance and with MDR TB. So we can use bedaquiline, pritomanid, and linezolid. This is called as a B-PAL regimen. So there is good efficacy, almost 80 to 90% efficacy in treatment with just a treatment regimen lasting for 6 to 9 months. And if the patient does not have a fluoroquinolone resistance, if the patient is just an MDR TB, bedaquiline, pritomanid, linezolid, and moxifloxacin is the suggested regimen, again for 6 to 9 months. So we see how this new treatment has completely cut short the treatment of tuberculosis, especially for the drug-resistant tuberculosis. Now, coming to the drug-sensitive tuberculosis treatment. So the drug-sensitive tuberculosis treatment, the basic regimen still remains the same. We have 2 months of RHZD, that is 2 months of rifampicin, isoniazid, pyrazinamide, and ethambutol, which is followed by 4 months of rifampicin with isoniazid with ethambutol. Pyrazinamide is dropped in the continuation phase. So we have the initial intensive phase followed by the continuation phase. 6 months of treatment is usually enough for pulmonary tuberculosis treatment after confirmation of sputum examination. So initially when the patient presents to you, the first step is to confirm the diagnosis of pulmonary TB or extrapulmonary TB. For pulmonary TB, the first step is to check the sputum. Do the AFB gene expert straight off. We don't have to waste time by doing the AFB smear examinations, and also get an AFB culture. In the gene expert test, we will come to know about the rifampicin resistance, whether it is present or not. If there is no rifampicin resistance present, it is drug-sensitive tuberculosis and you can directly start treatment. Suppose it is extrapulmonary, that is TB of the any other organ or TB meningitis suspected or lymph node, try and get a biopsy from that part or do a fluid examination of the CSF or the pleural fluid. This will give us if the drug is if the gene expert comes positive, there is no issue. If not, we will need a tissue which is confirming that there is caseous necrosis, where there is epithelioid granulomas. This will confirm the presence of tuberculosis or give a very high suspicion, and then we can start the tuberculosis treatment. So basically you have the intensive phase for 8 weeks and then the continuation phase. The continuation phase may need to be extended up to 24 weeks in certain forms of TB like CNS TB, skeletal TB, and disseminated TB, or in slow response of tuberculosis. And the doses are isoniazid 5 mg per kg per day, rifampicin 10 mg per kg per day, pyrazinamide 25 mg per kg per day, ethambutol 15 mg per kg per day, and streptomycin 15 mg per kg. And the number of tablets are depending on the weight basis. This is for either you can give this as per the NTEP protocol, or these drugs are also available as single drugs in the pharmacy, and we can prescribe it as per the daily recommended dose. Always remember that the TB drugs are all to be given together. And you should not give a split like pyrazinamide. If it is you're giving 750 mg, you should not give it twice a day, but you should give both tablets at the same time, because you want a high peak of the drug in the bloodstream. Continuation phase with 3 drugs, preferably steroids may be used in TB. Steroids need to be used in some forms of TB, especially in TB meningitis, and it is given in a tapering daily dosage. And monitor the liver function test, observe for clinical improvement, closely observe for development of any complications. Special considerations for adult abdominal TB: extend duration of treatment in cases with inadequate response, consider endoscopic dilatation, refer for biliary drainage, jaundice due to biliary obstruction. Special considerations for intraocular TB is, again, you may give 7 months of continuation phase, and you may need to give corticosteroids. And systemic corticosteroids may be needed for severe inflammation if there is a uveitis. So basically, this is the special consideration for the treatment of drug-sensitive tuberculosis in adults. Pediatric TB, the recommendations remain the same. Only the dose of isoniazid is increased in pediatric tuberculosis. It is 7 to 15 mg per kg, unlike 5 to 10 mg per kg in the adults. Pyrazinamide 30 to 40, ethambutol 15 to 25. So the doses are increased. Again, for pediatric TB meningitis, we may have to give steroid. Usually prednisolone is given, and it is tapered over 4 weeks. And bone tuberculosis, you may need to give a longer duration of treatment. Abdominal TB, generally steroids are not recommended, and they may need, however, surgical treatment if there is any obstruction. But do not start empirical ATT in patients with recurrent or chronic abdominal pain, or in chronic patients with chronic diarrhea. So basically, we need to collect the sputum sample, conduct the chest radiograph, evaluate the patient, see the weight, see the history, see the comorbidities, do the laboratory testing, see the platelet count, creatinine, see for pregnancy, HIV testing, CD4 count, diabetic screening. Newer regimen has been recommended for drug-sensitive tuberculosis, only 4-month rifampicin and moxifloxacin. So it's rifapentin, moxifloxacin, isoniazid, and pyrazinamide given together for only 4 months. So this recommendation has come in view of the high sensitivity of moxifloxacin, and also with a view to reducing the duration of treatment of tuberculosis, and also keeping ethambutol out, thus reducing the optic neuritis and the complications of 6 months of ethambutol treatment. And so basically, for the simple MDR-TB, BPAL-M, as we already discussed, has been recommended just for 6 months: bedaquiline, pritomanid, linezolid, and moxifloxacin, rather than the 9 months of the or 18-month longer regimens have been recommended. All oral regimens for MDR-TB, longer regimens for MDR-resistant TB. So we have already discussed these group drugs. So basically, this was a short summary of the treatment of tuberculosis, how it has evolved over the last few decades. So starting from only streptomycin, we came to the primary drug treatment of tuberculosis, that is 4-HREZ and 2 months of 4-drug treatment, and followed by 4 months of 2-drug treatment. Then 3-drug treatment, that is isoniazid, rifampicin, pyrazinamide, ethambutol in the initial phase, followed by HRE, that is isoniazid, rifampicin, and ethambutol in the continuation phase. So this is for the primary drug-sensitive tuberculosis. For drug-resistant tuberculosis, there are various newer modalities of treatment which are now available. Newer drugs are available. There are many more in the pipeline. So basically, we need to treat now for latent tuberculosis, see if the patient has subclinical tuberculosis, active TB, cavitary TB, and see whether the patient has any drug resistance, see whether there is drug tolerance. So this is the pathology showing how there is a caseous necrosis, how in the lymph nodes itself there are cords formed, and there are intracellular macrophages where the TB germs can hide, and how the germs can be cultured. This is a slide showing the various new drugs which are under development. for treatment of tuberculosis. So there's a whole array of drugs which are targeting various which are targeting the like ATP synthase, ribosome, cell wall, gyrase, cholesterol catabolism. So these different steps of TB organism metabolism is targeted by these drugs in order to kill the Mycobacterium tuberculosis. So these are the various studies which are going on with bedaquiline, delaminate, linezolid, levofloxacin, clofazimine. So all these new drugs, there are huge number of studies. There are number of studies which are going on, the Simplicity TB trial, Beat TB trial, Stream trials, NTB trial, Intense TB trial, the first shot, which are documenting the efficacy, side effects of these medications. So looking at all these things, yes, we can definitely think that the day will come when tuberculosis can be ended by giving the correct regimen, by diagnosing early, by giving the preventive tuberculosis treatment, by treating the drug-resistant tuberculosis, and by having these medications available free of cost through the government chain. So that is my message for all of you.
Thank you so much, ma'am, for the wonderful presentation. So with your due permission, shall we move forward to our question answer round?
Yes.
We have received questions. So first question is, how pulmonary tuberculosis treated in patient with HIV infections and AIDS?
So basically, pulmonary tuberculosis in HIV treatment is similar to what we give in patients without HIV. Only thing is, we start as soon as the tuberculosis is diagnosed, you first start with the tuberculosis treatment. If the patient is not already on HIV treatment, wait for 4 to 8 weeks after starting the TB treatment, and then only start the HIV medications for these patients. We must remember that there can be drug interaction between rifampicin and some of the anti-HIV medications which are being used. So accordingly, the dosage of the drugs may need to be changed. The basic regimen remains the same for the drug-sensitive tuberculosis. 4-drug AKT is started, and so if there is no rifampicin resistance for MDR tuberculosis, the MDR TB treatment as per the protocol which is available is started, and the HIV medications are started after 4 to 8 weeks. We must wait for a period of time after starting the TB treatment and then start the anti-HIV medication, because if both are started together, there is a high chance that the patient may develop an iris-like reaction, which is a hypersensitivity type or a flaring up of the disease because of the increased immunity which the patient gets after starting the HIV medication.
Thank you so much, ma'am. We already received many questions. I am just sorting and taking some of them. The next question is, which surgical interventions are indicated for MDR TB?
So basically, if it is a localized disease, like for example, if the patient has say only an upper lobe cavity, right upper lobe cavity, then you can do a lobectomy. If the patient has extensive disease, cavitary disease on both sides of the lung, then it becomes difficult to do a surgical treatment because you cannot remove all parts of the lung. But we can remove even up to pneumonectomy. If only whole of one lung is involved, even the whole lung can be removed as part of a surgical treatment for MDR TB. Usually the surgeons will wait for a period of at least 6 to 8 weeks after starting the TB treatment and then go for the surgery.
Thank you so much, ma'am. We are already over the time, but we will take 2 more questions. The second last question is, what causes the antigenicity of mycobacteria in tuberculosis?
So it's basically the cell wall. Antigenicity in the sense it is the mycolic acid in the cell wall which is responsible for the antigenicity and for in the tuberculosis organism. And usually the antibody which is seen is not really the antibody, it is more of an interferon gamma, which is like a reaction to the tuberculosis germ which is seen. There are no typical TB antibodies as such which are formed. What happens is that the tuberculosis germ multiplies, then the epithelioid granulomas are formed around that, which walls it off, and this is how the germ gets contained. And the treatment which is given, all the anti-TB medications, they basically target various parts of the TB organism, that is the cell wall or the mRNA or the ribosome, to prevent the multiplication of the TB organism. It is not really antibody mediated. Even the vaccine which is there is not an antibody, but it is a BCG vaccine, which is the TB germ is serially cultured, and a very weak type of germ is then injected into the body. The protein is injected, and this produces an immunological response. It's not so much antibody mediated.
Thank you so much, ma'am. The last question of today's session is, what are the most common sites of extrapulmonary tuberculosis?
Most common what we see is lymph node, pleural effusion, abdominal TB, TB meningitis, spine TB. These are the common sites what we see.
Thank you so much, ma'am, for answering all the questions. I think all the participating doctors, you have got your answers. And I would like to thank Professor Dr. Jayalakshmi, ma'am, for his beautiful, wonderful lectures. And I would also like to thank our participating doctors for joining today's session and make the session a successful one. So, ma'am, with your permission, shall we conclude the session here for today?
Okay, thank you.
Thank you so much, ma'am. Thank you everyone for joining.